Hello, dear students. This lecture is on acute respiratory viral infections, which are among the most common infections worldwide. In the Northern Hemisphere, winter ushers in cold and flu season. People with runny noses and sore throats are often unsure if they have the flu, just a cold, or COVID-19. These diseases have somewhat overlapping symptoms, so it is often difficult to identify the viral culprit without molecular testing. In this lecture, I will explore the differences between diseases caused by different respiratory viruses in terms of their symptoms, epidemiology, and pathogenesis. I will give a brief description of some diseases from this group and consider in more detail the characteristics of influenza, one of the most serious among them. I will also describe methods of specific diagnosis, as quick and accurate viral identification is important to help with critical bed management decisions in the hospital setting. Approaches to treatment and prophylaxis will be discussed as well. The lecture is prepared and delivered by me, Associate Professor MD, PhD Ivetta Shestakova. The purpose of the lecture to learn the main principles of clinical and laboratory diagnostics and prevention of acute respiratory viral infections. Learning objectives to describe the most common viral diseases with an airborne transmission mechanism, to establish the role of influenza and other ARVIs in human pathology, to deepen the knowledge about the clinical symptoms of ARVIs, explain the clinical manifestations of influenza and other ARVIs based on the pathogenesis of these diseases, to introduce modern methods of laboratory diagnostics, principles of treatment, and prevention of influenza and other ARVIs. Diseases with an airborne transmission mechanism spread through the air in infectious aerosols produced by coughing, sneezing, or talking, or more often by hand-to-hand contact with subsequent passage to the nostrils and the eyes. This is the most common mechanism of infection transmission. Its name well characterizes the way in which infectious disease pathogens are transmitted. Microorganisms concentrate on the mucous membranes of the respiratory tract, and when, together with droplets of saliva and mucus, they are released into the environment during sneezing, coughing, or talking, they enter the susceptible organism in the form of an aerosol with a stream of inhaled air. Moreover, while large droplets settle quickly, the finely dispersed aerosols remain airborne for a long time and travel over considerable distances. Pathogens resistant to drying can also be found in dust particles. On this slide, you can see the main characteristics of ARVIs. They spread rapidly. Most of them are highly contagious. Seasonality is typical for them. They usually occur in the autumn-winter or winter-spring period. The clinical picture includes respiratory symptoms and manifestations of general intoxication. The diversity of pathogens causes a variety of clinical manifestations. These diseases can have serious health consequences, so it is important to take measures for their prevention and timely treatment. For the vast majority of these diseases, non-specific prevention methods are available, such as wearing masks, hand washing, and avoiding contact with sick people. Vaccination is recommended only for some of them. Acute respiratory infections, ARIs, are a large group of polyetiological infectious diseases that cause respiratory syndrome and symptoms of general intoxication. ARVIs is a group of ARIs caused exclusively by viruses. The widely used term for these diseases is the common cold. The common cold is an umbrella term for diseases caused by over 300 different respiratory virus strains. ARIs occurs everywhere and at any time of the year. They account for 75% of all infectious diseases, and in epidemic years they increase to 90%. According to the WHO, every third inhabitant of the planet suffers from ARIs every year. ARIs take the first place among the causes of temporary disability. Etiological factors of ARIs are listed on this slide. It can be different bacteria, rickettsia, mycoplasma, chlamydia, and many viruses. And now let's talk about ARVIs, which is a group of diseases of viral etiology. As I said previously, the causative agents are about 300 different viruses, representatives of 4 RNA and 2 DNA containing families. This diversity of viruses partly explains the variety of symptoms experienced by patients, while the host immune response and comorbidities such as COPD further explain the differences in symptoms in individuals. This slide demonstrates the most common pathogens that cause ARVIs. As you can see, each virus has several serotypes. Viruses of the same serotype do not produce cross-immunity. Hence, people can contract a disease caused by the same virus multiple times annually. The relevance of ARVIs is determined by the following factors. Most of them are highly contagious and spread rapidly. Can cause sporadic cases and epidemic outbreaks followed by significant economic losses due to their widespread distribution and high incidence. Lack of cross-immunity contributes to increased incidence. And at last, the ability to persist in the body can lead to development of chronic diseases of breathing system, heart, nervous system, kidney, eyes. Pathogenesis of ARVIs consists of the following steps. Virus replication and injury of respiratory tract epithelium, viremia and vascular lesions. Some viruses can damage other tissues and organs such as nervous system, hair, lymph nodes. Development of cell immune response in the early period of the disease and serological protection which develops later eventually suppress virus and damage finally recovery. Each disease from the group of ARVIs affects distinct region of the respiratory tract. Therefore, it is important to separate the symptoms of rhinitis, pharyngitis, laryngitis, which develop due to damage of upper respiratory tract, and tracheitis, bronchitis, and bronchiolitis, which develop due to affection of lower respiratory tract. This slide demonstrates the symptoms of the above symptoms. Nasal congestion, impaired nasal breathing, sneezing, and nasal discharge all are signs of rhinitis. Pain when swallowing, hyperemia and edema of the mucous membrane of the posterior wall of the pharynx and soft palate, its granularity and possible hemorrhages are signs of pharyngitis. Hoarseness, dry barking, coughs, jitter, difficulty breathing, hyperemia and edema of the laryngeal mucosa are signs of laryngitis. Itching sensation behind the sternum, dry cough accompanied by pain behind the sternum are signs of tracheitis. Cough with mucous sputum, difficulty breathing, and scattered dry wheezing in the lungs can develop in patients with bronchitis. And cough with little sputum, shortness of breath, obstructive emphysema, and acute respiratory failure can develop in patients with bronchiolitis. And now briefly about some ARVIs, and start with rhinovirus infection. Rhinoviruses are the most common viruses that cause colds followed by coronaviruses. Rhinoviruses are named from the Greek rhinos, meaning of the nose. This name relates to the fact that rhinoviruses replicate best at the temperatures found in the nose, 33 to 35 degrees Celsius. In the diagnosis of rhinovirus infection, the following may be noted. Epidemiological data indicates that cases of a similar disease have been identified in other people in spring or early fall. Abundant serous or serous mucus rhinorrhea is typical for this disease. Mouth or throat is possible, but not common. And there is almost no toxic symptom. So body temperature usually is normal, and no fatigue, headache, etc. Adenovirus infection is characterized by subacute onset, moderate toxic symptom. The virus escapism to the cell of the mononuclear phagocyte system causes the polymorphism of clinical symptoms. These are generalized lymphadenopathy, hepatolional syndrome, and hyperplasia of lymphatic formations of the respiratory, digestive, urinary tract, and conjunctiva. This slide demonstrates clinical classification of adenovirus infection. Pharyngoconjunctival fever is the most typical clinical form of AI. ARVI in the form of rhinopharyngitis or rhinopharyngotonsillitis. The next is conjunctivitis and keratoconjunctivitis with affection of eyes. Hemorrhagic cystitis, pneumonia, and adenovirus diarrhea also are clinical forms of adenovirus infection. Adenovirus diarrhea or mesoadenitis usually develops in children. Parainfluenza is characterized by gradual onset, signs of toxic symptoms such as body temperature, fatigue, headache are moderately pronounced. All parts of upper respiratory tract can be affected, so symptoms of rhinitis, pharyngitis, laryngitis, tracheobronchitis can develop in patients with parainfluenza, but laryngitis is believed to be the most frequent and typical manifestation of parainfluenza syndrome. Infection leads to swelling of the laryngeal mucosa, which interferes with normal breathing and produces the classic symptoms of barking or brassy cough, inspiratory stridor, and a hoarse voice. Because the space between the vocal cords is the narrowest part of the airway, in some children significant swelling can lead to airway obstruction requiring emergency care. Therefore, stenosing laryngitis or false croup is a serious parainfluenza complication, and this complication usually develops in children. Respiratory syncytial infection. Respiratory syncytial virus or human orthopneumovirus is a single-stranded RNA virus. The name comes from the large cell called syncytia that form when the infected cells fuse. Respiratory syncytial infection can present with a wide variety of signs and symptoms that range from mild upper respiratory tract infection to severe and potentially life-threatening lower respiratory tract infection requiring hospitalization and mechanical ventilation. While respiratory syncytial virus can cause respiratory tract infections in people of all ages and is one of the common childhood infections, its presentation often varies between age groups and immune statuses. Reinfection is common throughout life, but infants and the elderly remain at risk for symptomatic infections. Infection rates are typically higher during the cold winter months. Hospital outbreaks also are possible. Respiratory syncytial virus is a notable pathogen in all age groups, causing bronchiolitis in infants, common colds in adults, and more serious respiratory illnesses such as pneumonia in the elderly and immunocompromised. The typical clinical picture is a combination of mild to moderate toxic syndrome with rhinorrhea and lower respiratory tract involvement. Changes in the lungs, wheezing and rales, weakened or hard breathing in certain areas during percussion, alternation of emphysematous and dull areas, shortness of breath, tachypnea indicate bronchiolitis and/or pneumonia. Radiological findings are characteristic of interstitial pneumonia and bronchitis, enhanced vascular pattern on X-rays, and ground glass opacities on CT scans. Clinical forms of respiratory syncytial infection according to ICD-10 you can see on this slide. They are bronchitis, bronchiolitis, and pneumonia caused by respiratory syncytial virus. The main characteristics of enterovirus diseases are as follows. With the exception of rhinoviruses, which also belongs to group of enteroviruses, the peak of infection occurs in the summer. Mainly affects young children. Clinical manifestations are polymorphic. Large number of clinical forms of ED exist. Isolated clinical forms are very rare. Short duration of fever and often in 2 waves is typical for enterovirus diseases. Clinical forms of enterovirus disease are presented on this slide. Vesicular pharyngitis or herb angina, which is characterized by sore throat, small vesicles appear on the soft palate and tonsils, which after 24 or 48 hours turn into painful erosions, along with high fever and other signs of toxic symptom. Enterovirus exanthema or hand-foot-mouth disease is characterized by macular-papular rash on the trunk, face, extremities, including feet and palms. And this disease usually lasts during 2 or 3 days. Epidemic myalgia or pleurodynia or Bornholm disease is characterized by chills, fever, severe paroxysmal pain in the muscles of the chest, abdomen, lower back, legs. In some patients, it can mimic myocardial infarction or gastric ulcer disease. The next clinical form is aseptic meningitis, which is characterized by severe headache, vomiting, stiff neck, high body temperature, and changes in liquor can be found. The next clinical form is enterovirus diarrhea, which is characterized by vomiting, abdominal pain, meteorism, frequent loose stools. Non-specific febrile illness or minor illness or summer flu, which is characterized by high fever during 1 to 3 days. And other forms: conjunctivitis, myocarditis, hepatitis, encephalitis, and poliomyelitis. In this picture, you can see an anthema on the soft palate of a patient with herb angina. The following images show a skin rash in a patient with hand, foot, and mouth disease. The skin on the palms of the hands and soles of the feet is affected. The rash is localized on the face as well as other areas of the body. The next part of the lecture is about influenza. Influenza is an acute infectious disease with periodic epidemic spread caused by influenza viruses and characterized by sudden onset, pronounced general intoxication, and symptoms of tracheobronchitis. It is usually self-limiting disease but can cause mild to severe illness and at times can lead to death. This is one of the most common, highly contagious and severe diseases among all airways. It is recorded on all continents. An important feature of influenza is its ability to spread rapidly and widely, sometimes globally. Regional socioeconomic losses during influenza pandemics are equivalent to losses during military operations. Influenza is considered the classic emerging infection and is responsible for annual epidemics and sometimes global pandemics. The virus attack rate ranges from 10 to 30% in all regions of the world. Currently, the severity of flu and mortality among certain risk groups is increasing. The mortality rate is not as high as for some other infectious diseases. For example, the mortality rate for meningococcemia is 10 to 20%, but it is significantly higher compared to the common cold. 80 to 90% of deaths occur in people over 65 years of age, mainly from pulmonary complications. The causative agent is an RNA-containing influenza virus, member of the orthomyxovirus family. Phylogenetically, there are 3 types of influenza viruses that differ based on their host range, genome structure, and surface proteins. Influenza A and B are the main types circulating in humans. Influenza C virus is detected less frequently and usually causes mild infections and thus does not present public health importance. Most pandemics have been caused by influenza A viruses. Influenza A viruses are further classified into subtypes according to the combination of the proteins of the surface of the virus, hemagglutinin H and neuraminidase N. These H and N surface proteins are antigens that work together to enter host cells. They are recognized by the immune system and are capable of eliciting an immune response, including the production of antibodies. There are 16 types of H proteins with the first three hemagglutinins H1, H2, and H3 found in human influenza viruses. There are 11 subtypes of neuraminidase. Influenza viruses are named as H1N1, H3, and 2X, depending on the combinations of H and N. To unambiguously describe a specific isolator virus, researchers use the internationally accepted influenza virus nomenclature, which describes virus type, geographic origin, strain number, year of isolation, and virus subtype. As an example, you can see on this slide. A stands for the genus of influenza. Fujian is the place this specific virus was isolated. 411 is the laboratory reference number that identified it from other influenza viruses isolated at the same place and year. 02 represents the year of isolation, 2002. H3 stands for the third of several known types of the protein hemagglutinins, and 2 stands for the second of several known types of the protein neuraminidase. One of the important features of the influenza virus is its variability. Changes in hemagglutinins and/or neuraminidase lead to the emergence of new antigenic variants of the virus. People who have previously had the flu do not have antibodies against the newly created variant. Thus, the person becomes susceptible to the new variants of the flu. It is the ability of the influenza virus to change that explains the emergence of epidemics and pandemics of the disease. Periodic pandemic outbreaks occur when a strain of influenza with significantly different surface proteins emerges, resulting in higher mortality rates. However, survivors develop some immunity and eventually the virus reverts to normal seasonal influenza, persisting in the population until the next influenza pandemic. Minor changes in the hemagglutinins structure that allow the virus to remain within the same subtype are called antigenic drift. In both the northern and southern hemispheres, influenza resurgence occurs every winter, driven by mutation in the genome that allow it to evade antibodies produced in response to a previous influenza strain. This mechanism underlies epidemic increases in incidence. The complete replacement of hemagglutinins and/or neuraminidase with a new antigenic variant is called antigenic shift. Antigenic shift is the process by which two or more different strains of a virus or strains of two or more different viruses combine to form a new subtype having a mixture of the surface antigens of the two or more original strains. The term is often applied specifically to influenza, as that is the best known example, but the process is also known to occur with other viruses such as Visna virus in sheep. Antigenic shift is recorded once every 10 to 12 years and leads to the emergence of pandemics. Influenza A viruses are found in many different animals, as you can see at this picture. Wild birds are considered the main reservoirs of the influenza virus. You can see them in the center of this picture and are infected with all known existing strains. From there, the virus is transmitted to domestic poultry, to dogs and chickens, mammals such as pigs, whales, horses, seals, and humans. Each animal species is infected with a distinct strain of the virus. Periodically, strains from different hosts can co-infect a single animal species, leading to genome sharing through a process called reassortment. Reassortment is the mixing of the genetic material of a virus species into new combinations in different individuals. The product of reassortment is called a reassortant. Antigenic shift is a specific case of reassortment that results in a phenotypic change. The classical example of reassortment is seen in the influenza viruses, whose genomes consist of 8 distinct segments of RNA. These segments act like mini chromosomes, and each time a flu virus is assembled, it requires one copy of each segment. If a single host, a human, a chicken, or other animal, is infected by 2 different strains of the influenza virus, then it is possible that new assembled viral genome is created from segments of the co-infecting strains, some coming from one strain and some coming from the other. The new reassortant strain will share properties of both of its parental lineages. Reassortment is responsible for some of the major antigenic shifts in the history of the influenza virus and is associated with the severity of the flu. The 1918 Spanish flu, 1957 Asian flu, and 1968 Hong Kong flu pandemics were caused by flu strains that resulted from the assortment of an avian virus and a human virus. The H1N1 virus responsible for the 2009 swine flu pandemic had an unusual mix of swine, avian, and human influenza RNA sequences. In all of these pandemics, mortality rate was high. This slide shows the main stages in the pathogenesis of influenza. Penetration and multiplication of the virus in tracheal and bronchial epithelial cells with their subsequent destruction and inflammatory response in the mucous membrane is the first step. Then viremia with intoxication, microcirculatory disorders, decreased immune response develop. Then bacteremia complications and exacerbation of chronic diseases also are common due to microcirculative disorder, depressed immune response, and other factors. And ultimately, building immunity promotes recovery. Influenza is characterized by short incubation period of 1 to 2 days. It has ranged from 18 to 72 hours. Sudden onset, usually flu knocks you off your feet. There are 2 main symptoms in the clinical manifestations of influenza. Pronounced intoxication, which is characterized by chills, high-grade fever, severe headache, myalgia, arthralgia, fatigue, sometimes extreme, and catarrhal syndrome in the form of tracheitis and tracheobronchitis, which is characterized by pain behind the sternum, infrequent dry cough, scratchy throat, and nasal congestion. Systemic symptoms may precede catarrhal ones. Illness generally resolves over 5 days. and the convalescent period lasts during 1 or 2 weeks. The criteria for diagnosing influenza are as follows. Epidemic rise in incidence during the cold season, acute sudden onset of the disease, combination of significantly pronounced toxic syndrome and tracheobronchitis, appearance of the patient, it is described as a face of a crying child, diffuse bright hyperemia of the oral mucosa, burning throat. In the following days, the mucosa acquires a cyanotic hue, the vascular network becomes noticeable, which is explained by vascular paresis. A CBC test reveals leukopenia with relative lymphocytosis and normal ESR. Complications of influenza are divided into 2 groups. The first one includes complications caused by the influenza virus, among them hemorrhagic pulmonary edema, toxic encephalopathy, toxic shock syndrome, Ray's syndrome. Ray's syndrome is a rare but a serious condition that causes swelling in the liver and brain. It can occur at any age but usually affects children and teenagers. In Ray's syndrome, blood sugar usually drops while the levels of ammonia and acidity rise. The liver may also swell and fats may build up. Swelling may occur in the brain. This can cause seizures, convulsions, or loss of consciousness. Mortality rate is high, and about a third of those who survive are left with a significant degree of brain damage. Aspirin has been associated with Ray's syndrome in children or adolescents with influenza or chickenpox and should therefore be avoided in such patients. Glomerulonephritis, possible development during the convalescent period. The kidneys are affected by immune complexes, which appear at the period of convalescence. Cold is often a trigger of these complications. Thus, the patient should avoid hypothermia during the recovery period. Guillain-Barré syndrome and myocarditis. The next group includes complications due to a secondary bacterial infection. It can be pneumonia, otitis, sinusitis, and sepsis. Rarely, humans can be infected with the avian strain directly from a bird. In this case, a more severe illness develops. You can see the characteristics of avian influenza H5N1 on this slide. Infection occurs through airborne dust. Diarrhea and cough with blood impurities can develop in some patients. Diffuse bilateral confluent infiltrates are seen on X-rays of the chest or ground glass opacities on CT images. Acute respiratory distress syndrome and acute respiratory failure are more common in these patients, and complications such as encephalitis, renal and hepatic failure develops more often than in patients with seasonal flu. In 2009, an outbreak of the so-called swine flu pandemic was recorded. You can see the main features of this disease on this slide. The virus was created as a result of reassortment of human, avian, and swine influenza viruses, which led to its higher pathogenicity. People under 45 years of age, especially those with stage 3 for obesity and diabetes were more vulnerable. They had a higher risk of infection and developing more severe diseases. In adults, diarrhea and vomiting took place in 25% of cases. Tracheitis, one of the main symptoms of the flu, may be absent in these patients. Hemorrhagic pulmonary edema was more frequently reported. In hemogram, essential leukopenia, neutropenia, thrombocytopenia develop and were more often than in patients with seasonal flu. Specific laboratory diagnostics of the flu and other RBIs. Throat swabs, nasopharyngeal washes, or sputum can be examined using PCR, IHA, and IFR. PCR is the gold standard for diagnosing viral infections, but is used primarily for the diagnosis of influenza, as only this disease is treated with specific antiviral therapy. Therefore, laboratory confirmation of the diagnosis is important. There is a rapid diagnostic test for detecting the antigen of a number of ARVIs using immunochromatographic analysis. Result can be obtained in 30 minutes. Immunofluorescence reaction is also rapid but requires special equipment and is only cost-effective when testing several dozen blood serum samples at a time, which limits its use in practical medicine. Routine serological blood tests such as complement fixing reaction, hemagglutinin inhibition reaction, and indirect hemagglutinin reaction require the study of paired sera. A fourfold increase in antibody titer is diagnostic. Samples of sera should be taken at an interval of 7 to 10 days and are used for retrospective diagnosis. Therefore, they are not common in practical medicine. Virological method, which is long and expensive, is not used in practical medicine. This slide shows the principles of treatment of influenza and other RBIs. Bed rest and light diet are recommended. Detoxification can be performed orally using juice, fruit drink, water, or parenterally using crystalloids and colloids for this. Ascorbic acid and rutin can be prescribed for strengthening the vascular wall of capillaries. Antihistamines of the second to third generations, antipyretics, mucolytics, bronchodilators if needed, nasal sprays, and antiviral drugs also are indicated for treatment of these patients. Antibiotics are recommended for the high-risk group patients and in case of bacterial complications. Antiviral drugs. Interferons and their inducers have non-specific antiviral effects. We can use a recombinant alpha interferon for local administration in the form of ointment or drops in the nose. Interferon inducers for oral administration such as amazon, mefenamic acid, and some medicines of this group also have direct antiviral action such as tiralon, cargocel, and protiflazid. All these medicines can be used for treatment of patients with RVIs. And there are a number of direct-acting antiviral drugs used for treatment of influenza. which belong to several groups of medicine. One of the most common medicines which are recommended for treatment of influenza belong to the group of neuraminidase inhibitors. Such medicines as oseltamivir for oral administration, zanamivir for inhalation, and peramivir for parenteral administration can be used. The next group, viral RNA polymerase inhibitors, baloxavir, marboxil, xafluza, can be used for treatment of influenza. The next group, fusion inhibitors, imustat, for example, and also influenza immunoglobulin can be used for treatment of patients with flu. The group of M2 channel blockers is no longer recommended as most strains of the virus are resistant to these drugs. So amantadine, rimantadine nowadays are now recommended for treatment of influenza. Non-specific prevention of influenza and other RVIs includes the following measures. Early detection and isolation of patients. Some of them need to be hospitalized. Avoiding mass events, distancing also is recommended. Introduction of quarantine, especially in schools and kindergartens. Masking, hand washing, using of indirect antivirals also is recommended for those who were in close contact with the patients. Vaccine and drug prevention of ARIs. Vaccination is widely used for preventing of influenza. Vaccination starts 2 or 3 months before the predicted epidemic. Vaccines are prepared from current strains according to the annual WHO recommendations. Every year, millions of influenza virus samples are analyzed to monitor changes in the virus antigenic properties and to inform the development of vaccines. And nowadays, a vaccination against respiratory syncytial virus is provided in the USA. Non-specific medicines are used for prevention of other ARIs. We can use interferon for local administration and interferon inducers for prevention of RBIs and suspensions of lysates of non-pathogenic bacteria for prevention of infections of bacterial etiology. Flu immunization is the most effective intervention available to reduce harm from flu and pressure on the health and social care system each winter. The number of flu vaccines increases every year. Trivalent vaccines are gradually being superseded by quadrivalent vaccines that cover an additional B virus strain. A quadrivalent recombinant influenza vaccine and a cell culture-based vaccine that do not contain egg protein are available. High-dose quadrivalent vaccines are available for patients more than 65 years of age. There are basic types of influenza virus vaccine. Live attenuated influenza vaccine for intranasal administration can be given to healthy people aged 2 to 48 years who are not pregnant and are not immunocompromised. And the second group is inactivated influenza vaccine. Um, we can use a sub-variants or split vaccine such as Vaxigrip, GC-Flu or Fluarix, and sub-unit vaccines such as Influvac. All vaccines are effective against current strains, i.e. those circulating in the current epidemic season. The key is to predict the strains of influenza virus that will circulate next season, as vaccines are made in advance. It is important to increase flu vaccine uptake in all eligible groups, including high-risk groups. Clinical high-risk group because of their increasing risk of death and serious illness from flu. Patients with chronic cardiovascular, pulmonary, kidney diseases, and diabetes mellitus belong to this group. Children, to reduce transmission within schools and in the wider community. Pregnant women, to reduce the risk of developing complications from flu during pregnancy and protect the mother. Frontline health and social care workers, to protect them, their patients, service users, colleagues, and family members. That's all the information I wanted to share with you. I hope it will be useful for you. Thank you so much for your attention.